Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. After the presentation today, we will conduct a question-and-answer session. If you'd like to ask a question throughout the call, you may press star then one and record your name. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn the call over to Karen Francis. Thank you. You may begin.
Okay. Well, thank you so much, operator. And good afternoon, everyone, and welcome to the third and final webinar for the 2015 Rural Behavioral Health Webinar Series. My name is Karen Francis, and I'm a principal researcher at the American Institute for Research and lead for the Rural Behavioral Health Initiative, along with my colleague who has joined us on the call today, Joyce Sabian, from the Mental Health Promotion Branch at Samhsa. This webinar series is supported by the Mental Health Promotion Branch at Samhsa in collaboration with the American Institute for Research, the Western Interstate Commission on Higher Education, and Affirma Solutions. So again, thank you for joining us this afternoon. Our webinar this afternoon will focus on innovations for crisis intervention planning, with a particular emphasis on such utilization in rural communities. Our presenter for today's webinar is James Wright. Mr. Wright is a public health advisor in the Suicide Prevention Branch, the Center for Mental Health Services at Samhsa. Mr. Wright serves as a government project officer for the National Suicide Prevention Lifeline, National Strategy for Suicide Prevention Grant, and the Crisis Center Follow-Up Grant. Mr. Wright also represents the Center for Mental Health Services in health information technology to include advances in mobile behavioral health and mobile application development. He is also the government project officer for states receiving the Garrett Lee Smith Grant Fund to provide suicide prevention screening, training, awareness, and outreach across the U.S. Mr. Wright represents Samhsa on several federal committees, some of which include the editorial board for StopBullying.gov, the Federal Partners for Bullying Prevention, and the Federal Interagency Committee on Traumatic Brain Injury. Mr. Wright previously managed psychiatric emergency departments for both Johns Hopkins Bayview Medical Center and Austin Travis County Integral Care. Mr. Wright is a veteran of the U.S. Army. So we're really excited to have James with us today to present and discuss the current challenges faced by many communities related to crisis response planning and implementation. James will also provide information about the components of behavioral health crisis systems and interventions. Further, he will describe Samhsa's mobile health application and innovation. And finally, he'll provide us with insights about the need for evaluation and impactful outcomes. So as is customary for our behavioral health webinars, we want to know who our participants are. So we have two polling questions that we'll now ask you to respond to. The first polling question is, what region of the U.S. is your community located in? And I'll give you a few minutes. There may be a little bit of a delay in the polling question, but so I'll just give you a few minutes just to respond. Okay, so I see from the Northeast and Mid-Atlantic region, about 33% of our participants represent the Northeast Mid-Atlantic region, as well as the Midwest region. We have, well, Midwest is now coming up to about 40%. We have 10% from the South and Southeast, and about 30% of our participants this afternoon are from the West, Northwest, and Mountain region of our country. So thank you for responding to that. And Laura, if we could move to the next polling question, please. And so our next polling question, again, in our efforts to learn who is on our call today, we'd like for you to tell us what role do you play in your program or in your community? And so we see there are about 44% of our participants this afternoon that record that their role is other than, management and administration, which is at 11%, 22% of clinical service providers, and we have 22% also that are community-based program providers. So again, thank you for your responses. Now I'd like to turn the webinar over to our very capable presenter, Mr. James Wright. James?
Oh, perfect. Thank you so much. And I would love to know what other is at some point, so if we get into the open discussion later, because it looks like we do have a good blend of representation from everyone from administration and clinical service, so that would be a great question to answer. And I'm waiting on my computer, the live meeting, to get to the next slide right now. Give us 1 second. I still see our little, there we go. Okay, so thank you everyone for attending today. And this was really an exciting presentation to put together because I really think it's an exciting time where we are, specifically when we look at crisis intervention services and what is available. And there's a definite difference in the availability of different structures, infrastructures, and systems. There's a big difference between rural communities and urban communities. So what I wanted to do today is kind of take a look at some of these innovations and what we really need to think about before we just start implementing new technologies. And so one thing to think about specifically around technology is that this is not an overnight process. Some of the problems are it does take patience and time to implement some of these, especially when we're looking at changing the ways we share information. So it may be in electronic health records or medical records in healthcare settings or behavioral healthcare settings and others. So it's not an overnight process. Even with a simple thing as an app download, we need to know what the ultimate impact of those are, and I'm going to talk a little bit more about those later. So it does really challenge us to change some of our thinking, especially in liability concerns amongst others. And so one of the areas that we know through some of our outreach efforts at Samhsa is that the rural areas, they really have a harder time getting the capacity and the capability of implementing some of these. And this is just one area in which we've seen some individuals struggle with is actually developing the systems as simple as the technology infrastructure, so bandwidth. Getting 3 bars on your phone instead of 1 or 0 can be challenging. So, 1 second. So I like to start with this to say if you've seen a state system, then, and the answer is you've seen a state system. We've seen when it comes to crisis services, there's a vast array of what services are out there, and it is very different from state to state and even community to community, a lot of times set up because of funding system structures. And so back in 2014, the National Council for Behavioral Health polled its individuals on its listserv and asked, what would you like to know? They had never, before then, they had never tackled this in their yearly meeting. And of that, there was a host of things that came out that people just wanted more information from. So they wanted to know, what are crisis residential services, or how do we do outreach and follow-up, specifically that continuity of care or care transitions piece, which again, I'm going to talk a little bit more about. How do we use things like electronic bed boards, and should we partner with law enforcement, or should we not, and how should that look? A couple other things, the need for focusing on high-frequency callers, so those that are calling into some of the crisis centers, or CIT training, which is crisis intervention training with police officers. How do we focus on that with them? And so there were a whole host of things that came out, a lot of which has not been identified, but you'll see a trend moving in the federal government with some of our new programs, such as the joint effort with Samhsa and the Center for Medicaid and Medicare Services on the Demonstration 223 grants, which are specifically looking at some of these things. So what I wanted to do today was identify the crisis system structure and then see how we're utilizing some technology to fix some of this. So with that, I'd like to say, where have we been? When we're looking at for individuals in crisis, it's been very limited in the past. You've had the emergency departments, you've had the police, and then we do have, and it gets sparser out in the western communities, crisis hotlines and crisis centers. But what we do know is there's a vast difference between those. funding requirements a lot of times shape the structure of the crisis centers themselves. And so what do we see out of that? Well, we see a system that's definitely fragmented, and it's crisis-driven. We see individuals continue to cycle through crisis services because those systems aren't necessarily as attached as they could be, and they don't a lot of times ensure continuity of care between that and outpatient services. And so individuals continue to cycle through. My position here at Samhsa is within the suicide prevention branch, so I like to look at where are we losing people to see how can we fix that. So definitely we have some huge gaps. We know that the highest risk time for an individual to die by suicide or have another suicide attempt is after discharge from an inpatient psychiatric hospitalization. So it can be in inpatient psychiatric hospital or the emergency department. So we see those deaths increasing directly after they leave. One of the big questions is, whose patient are they? Are they the hospital's patient, or are they the provider that they referred to's patient? Some of the technology I'm going to highlight a little bit later will actually try to branch those two initiatives, the ED and the ongoing behavioral health services. And so what else do we see? Well, we do see that the number of individuals being seen for a suicide attempt has been increasing, while, again, those that have been hospitalized have been decreasing. So they've been referred to other services, but the problem is half of those never receive those outpatient services once they are referred. So a little bit of background on suicide. Suicide is the second leading cause of death for those individuals that are aged 10 to 24. And is the 10th leading cause of death amongst Americans across the lifespan. And just a few notes for those in the United States. The number of suicides is twice that of homicides over the lifespan. And in 2013, which is the last year that we actually have data from, more than 41,000 people died by suicide. So I'd like to show you what it kind of looks like. Now, these are suicide rates among those in the United States. So when I looked at the polling question, I saw West, Midwest, Northwest. If you'll see, the darker areas are the higher rates of suicide. Not to be confused sometimes with the deaths by suicide. So some of the areas, I don't know if y'all can see my cursor or not, but some of the areas that are very light, like California or Texas or New York, those have the highest numbers, but the rates are not nearly as high. So you may see it be slightly disproportionate to those. But again, definitely the highest rates in 2013 are from the West. And that is, this is from the AFSP's website, so anyone can go on there, the American Foundation for Suicide Prevention. So the big question that we have is, with so many different services, where do we start? Well, what we're going to do in a second is ask another polling question, but these are some components of a comprehensive crisis system, but not all of them. So if you're not familiar with some of those, again, my contact information is going to be at the end of this, or I encourage you to do a little research on some of these. But really the difference, again, between like crisis stabilization beds, crisis respite or residential care. Again, we have a lot of states that have psychiatric emergency walk-ins that are different than the EDs. And then one of the most critical areas that we are finding that really reduces the amount of hospitalizations, reduces the amount of deaths by suicide and attempts by suicide on suicide are post-crisis follow-up engagement and support. So that notion of continuity of care and care transitions. And so what we want to do is we want to build a crisis service continuum. And this is kind of a flow that we're really starting to work on at the national level of identifying these through states, what pieces individual states have, and how they can ensure these individuals get in there. And again, as just a little heads up on a little bit later on this presentation, we're going to see how some new technologies are helping some of these transition-based areas. So with that, I think we have a polling question. Oh, wait. I went one too far.
No, you're good here, James.
Okay, so the polling question is, what components of a comprehensive crisis system exist currently in your community? So my computer is thinking, but is everyone seeing it?
Our computers are thinking too, James.
Okay.
Yes, here it comes.
So I'd love to know if for the individuals that are participating today, which areas you most know. Can they select more than one? Okay, here we go. Or are you only allowed to choose one? Hello? Karen?
Yes, the system will only allow the selection of one.
Okay. So if you see other people choosing some others, if you have one of them that are not chosen, please choose that so I can see if there's a array or not. Okay. Well, we have a few responses, so thank you. One of the things that I noticed with this is if the focus on hotlines and mobile crisis outreach teams, and I don't know with the individuals that specifically chose that, but we do know that a lot of hotlines and mobile crisis teams are linked together. So even to the point where they are dispatching the mobile crisis teams from the crisis hotlines or the chat lines, and so it would be interesting to know as well how many of you have those combined features. So with that, I'm going to continue on and briefly talk about the National Suicide Prevention Lifeline because some of the technology advancements specifically come out of there. So I think it's thinking. Do I need to hit the go button, Karen, or Laura, did you hit the next button?
So, James, before you move on, we have a Q&A section here. We're just wondering
Perfect.
if there are any questions that you could respond to at this time.
Perfect.
So the operator could open the lines, please.
Participants, if you would like to ask a question, please press star then 1 and record your name. Once again, to ask a question, you may press star then 1 and record your name.
So I can just go ahead and get us started. James, I don't know if you will talk about this subsequent part of your presentation, but could you describe what you mean by crisis respite?
Sure. So crisis respite is a in-between service between hospitalization. It's a voluntary service between hospitalization or crisis stabilization and discharge to the local community. So many times an agency may have beds that they operate within their agency, and so then you can actually admit voluntary individuals for a designated period of time that may or may not have medications administered during that time, or do whether it's med checks or do therapy, or it could be counseling-based services along with it, or outpatient programming as well. And so it is an in-between, which we would call a step down from the more intensive services. So they're very effective, and we see them run at a lower cost than hospitalization, for example.
Okay.
Were there any other questions?
Well, James, this is Joyce, and I'm just for folks on the call, I'm a project officer at Samhsa and one of the hosts of the call too. But I'm in conversations with some of my colleagues and grantees, wondering if you would just go to basics a little bit and help make that distinction between crisis intervention and emergency and disaster kinds of programs, so that there's a real clear understanding of how these different things are being defined.
Sure. So today I'm focusing mostly on behavioral health crises and crisis intervention of behavioral health. So you may have emergencies that occur, and I am going to highlight one app, a mobile app that focuses on disaster relief and response, but that would be for a natural disaster. Now, many times you may see overlap between responding to an individual who may have had a traumatic event and need behavioral health services, but not necessarily. So the majority of the talk today will focus on behavioral health crises, which means a crisis of an individual that's experiencing either a substance abuse or symptoms of a mental illness per se, to the point where they are suicidal, homicidal, severely psychotic, or unable to care for themselves or others, which is specifically looking at the crisis realm. Did that answer your question?
That was fabulous. Thank you.
Perfect. Okay, any other questions before we move on?
No questions from the phone at this time.
Perfect. Okay, so I wanted to talk a little bit about the National Suicide Prevention Lifeline. First, to know what the Lifeline is, you have to know what it's comprised of. And the Lifeline is comprised of 165 independent crisis centers. Now, a crisis center varies drastically from area to area. There's been estimates of over 1,200 crisis centers in the world, over 600 of them in the United States. So we would have the majority of those in the world currently. Again, most of them are set up based off their funding. Many are ran by volunteers, and they are not set up to receive reimbursable services. So they are standalone crisis centers that just operate phone-based services, or as we'll see in a second, chat or text. Again, the benefit of using these centers in the National Suicide Prevention Lifeline is they really are of the community, and the goal is to get an individual caller as close to a local crisis center as possible. So again, I said the Lifeline is comprised of these individual crisis centers. Anyone can dial 1-800-273-TALK or 8255. And again, even though it's a Suicide Prevention Lifeline, we like to state that this is for people in emotional distress or suicidal crisis. So you don't have to be suicidal to call. You're still going to get those individual centers that are in those local areas. They are trained to do suicide risk assessment. But again, they're really there in those local communities to provide you the care and the resources in which you need. Sometimes they'll be tacked onto larger base services so you can get behavioral health services through their agencies, but many times not. So what we do is we route all of these callers, and we have seen a steady increase since we've actually started this in 2005. Up to right now, we're projected to hit 1.7 million calls at the end of this year, which is the end of this fiscal year, the end of September. So there's been a couple things that they have done, and one that I'll talk about is the prompting of chat and text through email, actually. But before that, I wanted to talk about training. One thing that we really wanted to do with the National Suicide Prevention Lifeline, since it is statewide, every state in the nation does at least have a crisis center that's part of the Lifeline. What we wanted to do is try to disseminate training. So you, even at community levels, will want to try to get individuals in different areas kind of on the same page. And this is what we wanted to do with the centers, since they are independently owned and operated. So the Lifeline created, through supplemental funds, a program called Submersion. And so Submersion is basically a call center training, and it's an online training that can be taken by any worker. So in the so they would link through their network resource center if you are a member of one of the crisis centers, and you would choose one of 3 scenarios to go through. So for those, you would choose whether it's a third-party caller, an individual caller, or a veteran. And this is the first screen that you would see about choosing the scenario. And so you have this little helper in the bottom right, and they'll actually give you feedback as you're choosing your options. And so you'll actually go through and you will hear the individual's voice. Now, these were recorded by actual actors, and so they'll actually get feedback and actually have a conversation with an individual. So again, this is a direct caller scenario. It's a male calling in distress, and they do have the option of doing a tutorial beforehand, and they kind of choose which option they think is best. And then you have your coach in the corner. So you can, at any given point, go from communication to get a transcript of what you have done so far, and then you can look and see how things are going, and you can just click Communicate to return to the main screen. So the one thing that we wanted to do is that over the last 10 years now with the Lifeline, we've identified imminent risk guidelines and risk assessment standards that we wanted to disseminate. So this was one way to take those lessons learned and evidence-based practices and embed those within a training to get all of these centers asking the same questions and kind of going through the same protocols. So you, at this point, after you've gone through your conversation, you get to rate what the risk level is. So here you would raise risk level, low risk, medium risk, or high risk based off of the risk guidelines. Then after the training is concluded, you would get a rating on each of the key points. So these are just two of the key points, risk assessment and safety planning. But then there's more that you can go into. You can go into active listening, identifying reasons for living, support, etc. The thing that I like about this is that it doesn't necessarily hold back. It'll let you know in areas in which you aren't doing well, and you have to be careful because the caller can hang up on you. So we do encourage people to continue to take the training and to learn as much as they can about those callers. So again, it is one way to disseminate and really embed those practices in a wide system, in a nationwide system, because it's impossible, again, to train 165 centers face-to-face. Before you ever got done with the last training, you would need to probably retrain at least a third of them because people would have moved on. So it allows for really those practicing of those again, and there's no limit on how many you can take. So one thing we know with technology is we know that there's been a host of people trying to duplicate these efforts. Cognito Interactive, many of you may be aware of their programs. They are on the Samhsa's evidence-based practice registry, or NREP, the National Registry for Evidence-Based Practices and Programs, and several of their products are on there. And they're not specific to suicide prevention, so there's a lot of things that they offer. Here's just a few of them. They have a veteran-specific training, LGBTQ, chronic disease. They have an emergency department specific training, underage drinking, etc. So we've also seen state-specific emergency departments and behavioral health trainings being created. One example is Texas is working on an emergency department-specific training, and so is Tennessee. They're working on one. They've been working on one for the juvenile justice sector. And so what we're encouraging with the use of Samhsa funds is really to follow evidence-based or best practices. And again, we usually see people fall into the realm of either gatekeeper training, a screening training, awareness training, something like that. So they're really identifying a need and then trying to fill that, knowing that face-to-face interaction is not going to be quite possible over a large audience. So I'll pause here and ask, with at least the training section, before we get into mobile applications, are there any questions that I can answer? For the hotline or crisis centers, again, I'm the project officer for the National Suicide Prevention Lifeline, so if you have questions about a local crisis center, want to know more about how you can partner with them, who they are, any questions like that, please feel free to ask.
And as a reminder for participants on the phone, if you would like to ask a question, please press star, then 1 and record your name. Once again, to ask a question, you may press star 1.
Now, I see one Q&A up top. Is there a question in that box? I'm afraid to click it.
James, this is Laura. If you hit manage, you'll see the question is from Joyce.
Okay.
And we have no questions on the phone at this time.
Okay, well, I hope everyone at least knows how they can get in contact or partner with their local crisis centers, and for a few reasons. Number one is that it's good to know who you'll actually reach out to if you reference the Suicide Prevention Lifeline. But two, it's also a good way to get outcome data. And I'm going to talk about the importance of knowing what you're doing and how it's impactful with your planning moving forward. So I will continue on. So what you probably don't hear on a lot, and I don't, is that we're going to talk about mobile app development. I'm encouraging everyone to take out their phone and actually turn it on and get ready to download something. So again, when I said earlier, it's not just about downloading from the systems perspective, but I encourage everyone on the call today to download, open, start thinking about, after today's presentation, how you can use certain products like this, or how it doesn't necessarily work in your area, and what you would need, what you would like, what needs to be developed, what needs to be implemented in your current crisis intervention system. So many of the apps I'm going to highlight today have come out of the suicide prevention branch. One specifically, if you haven't heard of it, is called Suicide Safe. It is a suicide prevention tool for behavioral health and primary care providers. And what it does is it utilizes what we call our safety practice guidelines that we have shared with emergency departments, and they were developed based off of, again, nationally recognized practice guidelines. These have been implemented in emergency departments for some time. What we found, what the need was, they really needed to get additional emergency department personnel and others utilizing it along with examples and the ability to explore additional things that little card didn't give you when we would disseminate those. So what it helps you do is helps you learn how to use the card when working with patients, or the approach, not the card itself. And again, you can explore different case studies and scenarios, which are very important in the medical field, and we get a lot of feedback about how these work, or even how these don't work, and what we need to change. And so it gives you, again, some conversation starters, provides you some sample language and tips with talking with patients. And then one of the important things is it helps you locate options, treatment options, allows you to filter by distance and type, and share those really with those patients that you're seeing. And so if you're unfamiliar with that, again, I encourage you to take a look at it, and then pass that information on to anyone in your community who might be able to use it or willing to use it and provide you with feedback. One other thing that I did, I was lucky enough to be able to lead a app challenge back in 2013. So we were trying to bridge that link between discharge from emergency departments and access to care. And we know there's the provider side, but we also know there's the individual consumer side. And what we wanted to do was find a way to develop an application to help that individual who was just seen in the emergency department, who was at risk for suicide then. So they had to be suicide, or the focus was those that were suicidal at time of admit or within 48 hours of being admitted to the emergency department, and to provide them resources and support until they link to their next appointment. And so we did have a couple different things that had to be built in. They had to build in again, strictly safety planning and linking to the National Suicide Prevention Lifeline. But many of them that we saw, so before I continue on with that, I'll say, so what we did was we posed this challenge on challenge.gov, which allowed any individual, any agency that was I believe it was no, they could have been for-profit. It just had to be an application that wasn't previously developed, and they had to submit. It was open to the nation. They had to submit an app within a certain period of time for a prize. Basically, it was for prize money. And so we had roughly $100,000 of prize money that we separated out into $50,000, $30,000, and $20,000, so a first, second, and third place prize. And what we found is we received quite a few apps, and again, many of them implemented some of these other components, especially that ability to push communications between systems and app users, which was really amazing to be able to see your information that you are inputting into your phone be embedded with your medical provider or your behavioral health provider. So there was this large variation of features that people submitted on their apps. So we got to test out a whole lot of apps. And it brought a different perspective to these because we weren't necessarily focusing as much on the behavioral health field, but on the technology development perspective. And so we got a lot of tech companies that were like, this is an interesting problem. Let's see how we can answer this question. And so we got a lot of apps that or processes that maybe we wouldn't have thought of before. And so we did have, again, 3 individuals that placed first, second, and third, and I encourage you to take a look at their apps. Relief Link won. They were in first place prize. MyPsych and then Reach Z and Companion. Relief Link definitely had the live linking to the Samhsa treatment locator. So when it says right there in the middle, health centers, that's what they're linking to. And they had some services that were available offline. So if you were in an area in which you didn't have internet access, you could still link up with some of those. Your phone would have saved some of those resources. And it had built-in mood trackers, reminders for medication, and then it would show your trends over time. But it always had that ability to do safety planning and link up with emergency services as necessary. MyPsych was much broader. It was a broader behavioral health application that embedded this suicide prevention component within it. And then finally, Reach Z and Companion actually was 2 apps, one for the individual, and then the companion app was for the provider or third party that you wanted to share your information with. And so you could ask a provider to download or to be a part of this. It could be your clinician, whoever. And then you could push certain things to them, such as your safety plan, and have back and forth communications. And so we did see different takes on them, and these are just 3 examples of the many apps that we received through this contest. So moving on with additional apps that have been developed, and all of these will be specific to Samhsa or some of our grantees. Here recently, Samhsa released a no bullying app, KNOW. It's an app for parents and teachers. Again, it uses a lot of our information that we had a successful campaign on the Take 15, the 15 plus, really trying to get parents and caretakers to talk with their kids about bullying and bullying behavior. So you could develop profiles specifically on the app with your kids. You could also, again, it gives a little bit of feedback with rating the content. You could share some of the information. And we've seen quite a few individuals download this, which we're very excited of because it hasn't been out there for very long. So if you have not downloaded this, I encourage you to do so and to provide feedback on it. It's something that we're very proud of. One other app, and we were kind of talking a second ago about the difference between crisis intervention from a behavioral health standpoint and then maybe emergency, and then like a disaster response. And so Samhsa also created the Samhsa Behavioral Health Disaster Response app. This is for these individuals that are going to be working or deployed in disaster areas. And so it provides, again, local resources, specifically, again, linking up with our treatment locators and others. But it identifies, again, or provides the evidence-based resources of the disaster kit, which is an actual walkthrough of how to engage individuals that have been in a disaster. A good thing with this, again, is it does function with limited internet connectivity as well, because we know that during a disaster, a lot of technology infrastructures do go down or get overwhelmed. I was in Austin, Texas, when Hurricane Katrina came in, and even the individuals coming into Austin had flooded the networks where it was very difficult to even receive phone calls in certain areas at that time. And so we see those get bogged down, so it's good to have tools that are available when you don't have that connectivity. And so, again, a valuable tool for those first responders. And so it really does allow them to, again, we just had 4 points: be ready, be prepared, be confident, and to share these resources easily. People read through that for 1 second while I get a sip of water. Okay. One other app that has been developed here at Samhsa is our Underage Drinking App. And if you're familiar with Cognito's products, you'll see that the avatars look like this, because Cognito was one that helped work on this. And will this webinar be archived? Can people get access to it?
That's correct. Yes, they can, James. They will.
Okay, so there is a YouTube video. This video is roughly 3 minutes long, and I encourage you, if you have not seen it, to go ahead and copy that and open it up when we share this. I was having difficulty playing it in the webinar. But again, it kind of gives you the background and a little bit of the items that are embedded within the Underage Drinking App. But it's a game, and it helps you learn, again, the do's and don'ts of talking to kids about underage drinking. Again, it uses avatars, and you'll kind of go through the process of having that conversation, learning what to ask and how to get and keep the conversations going. So it's a different type of app, because this is one that does use an avatar basis, which our other apps do not. Okay, I wanted to share just a couple examples from grantees. So we have seen, again, in suicide prevention, some of our grant programs create apps based off of what their demand is at their local level. And so one on the left is the Ask About Suicide to Save a Life app. This was actually created out of Texas, the Mental Health Association of America in Texas, or Mental Health of America in Texas. And they really highlight a few key fundamentals. So what are the warning signs for suicide, how to ask an individual if they're in crisis, and then what are kind of those best practices and where can they get help. And that's a basic fundamental app for them. I'm going to kind of show a couple more from them as well. Another one is Suicide Safer Home. One thing we know is that we need to look a lot of times when an individual is suicidal at means reduction or restriction, basically helping individuals and families make their environment safe. Similar to an individual that has had too much to drink, you would not want to give them the keys to the car to drive. We do need to make sure an environment is safe for everyone, especially those that are experiencing suicidal behavior. Another one is My 3, which is a different take on it again. This is more of a connectivity approach. You see that you are linking up with 3 individuals that you trust, and you actually have contacts that you add and then you have things built into the app on those individuals that you can communicate with or that are supportive to you. So there are stories behind each person that you can actually add and you can build off of. So again, different takes and different user engagement. If you look at the first two, they're more information dissemination, and the third one is more user-generated content. So sometimes you'll see the difference between those apps based off of what's needed in those communities. So a couple of examples, I did just highlight the Ask app. Texas does have an interactive hope box that does allow for including user-generated content, and it promotes wellness by incorporating components of their health messages. They also have, which isn't on here, they have the suicide, this one's the Suicide Safer Home app again as well. It's a different version, and again, you can download that by searching Suicide Safer Home. I'll let people read that for 1 second. Okay, I am a grant project officer with the Garrett Lee Smith Youth Suicide Prevention Program, and one of the grantees that I have is New Jersey. And so a few things I wanted to highlight about New Jersey. What they wanted to do wasn't use apps per se. They wanted to use social media specifically to engage their communities, and they wanted it to be youth-led. Again, what they wanted to do is create a media campaign, and so they focused on access to care, as many do, community support, and positive friendships. You can kind of view a little bit more at jerseyvoice.net, but they wanted content that was created by youth, and they wanted this to be youth kind of owned and operated. And so they did this in a number of ways. They did their basic Jersey Voice. They did a media campaign specifically outreaching to youth. And then they wanted to host a youth awarded media festival and blog on their site. So they had other initiatives with a Facebook page along with Twitter feeds and other things. But again, the focus was to track youth involvement across New Jersey. Now, this is important and an important point that I want to get across. It was one thing to have a Facebook page or to have a content-driven page, but it's a whole other thing to start looking at the outcomes of those pages. So what was the purpose of having the page? Was it to disseminate information, or was it to increase help-seeking behavior? So what they wanted to know was, if we have a media festival, and if we're using this website, and if we're engaging youth, are they seeking help when they need to seek help? So what they started doing was sifting through all of these sites, the user-generated content that was being created amongst other sites, and tracking the ways they responded to individuals in crisis, and kind of changed the way that people use social media in New Jersey. So one of the outcomes that they actually looked at was the increase of crisis. They have two programs there, Second Floor Helpline and the statewide crisis line that includes the Lifeline. And they wanted to look at the increase of utilization of those programs because of this effort. So they could actually track when they had an increase in media campaign to an increase in help-seeking behavior, and how that got embedded into permanent structures. And so, again, I can't overemphasize the importance of trying to identify, regardless of what you do, the outcomes of the initiative, not just implementing an initiative. So definitely we need to identify what needs to be there, and then we need to identify whether or not it had an impact, albeit positive, neutral, or negative. Okay. One other example was a tribal example that I wanted to highlight today. This actually came again from a Garrett Lee Smith Youth Suicide Prevention Project, and they wanted to build community engagement, specifically around, again, inviting individuals to share their voice, their experience. So what they did was they actually created digital storyboards to increase the youth involvement. So they really saw this as a way to build their community and to start having the conversation around what historically can be a taboo subject around suicide and suicide prevention. And so this was one way that they did. So I encourage you, if you haven't seen, this is one link to their YouTube examples of their digital storyboards from Pyramid Lake. Really looking again at that creating social change. Okay, I'm going to move on real quick to, actually I think we're going to pause because there's a Q&A afterwards right before I get into, is there a Q&A afterwards? Yeah, I think we put Q&A one slide.
We shifted Q&A.
Yeah, we need to do the Q&A first, and then I'll get into Tennessee's target. I hit the button, but it's thinking. So we're loading a question and answer page. So at this point, does anyone have any questions, at least on applications or anything that I've presented on so far today?
And as a reminder, participants, you may press star then one to ask your question. Once again, to ask a question, please press star one.
Okay, James, I'll jump in. This is Joyce again. I wonder, these are all great apps, and I'm wondering if you just talk a little bit about the challenges in rural areas where, in some of your thoughts and experiences, you've provided some examples there of what might be considerations and in terms of planning for crisis intervention and how these apps might plug into those overall comprehensive plans.
Sure. So the first thing really is to identify what you have access to around crisis or suicide prevention. And so it's looking at what resources you currently have in your communities and then what you think you need. So do you need to enhance, for example, the care of an individual leaving an ED to additional services? Maybe you have a very strong system there. Maybe you just want to build upon it. Maybe you want to link up with a different community, for example, or you wanted to start creating a sense of community. And so really the first step is identifying what you have access to physically. So what systems are in place. And then looking at how can these additional technologies benefit those structures. So these aren't going to necessarily create a structure, but what they're going to do is they're going to help build upon the structures in which you have. So again, they could be looking at bridging the gap between services, or they could be looking at self-care. Many of the apps that were developed, say for the Suicide Prevention App Challenge, did have components of self-care in it. So you may know that you have a very limited resource in outpatient counseling, for example. Well, is there a behavioral health app that will really help specifically with those that are either waiting for outpatient counseling or maybe don't have access to it? So that's where searching for specific apps comes into play, and I kind of get a little bit further on into that. But there's a lot of apps out there. The one thing that you have to be careful of is you have to look at who created the app, how is it being updated, and what information and what resources are being provided. And so as an individual, I always like to say put yourself in the user seat and say, is this going to be beneficial to you if you needed it? Why or why not? And that'll start telling you in your community what you have and what you need, and if it's really going to fit in. Again, the most important thing is once you identify, a lot of these are at low cost or no cost. A lot of the apps that are out, all the apps I've showed today are free. So you can download them, but let's say you download the behavioral health, for the behavioral disaster response app. Are you then passing that app to all of those individuals that may potentially respond in a natural disaster? Also ask what additional trainings have they had, does it really fit in with what they're doing? And so that would be feedback that you would get back from those individuals. Does that make sense?
So, James, this is Karen. Another follow-up question. And you may have spoke about this, but how are these apps adapted for use by youth, young people, and in particular, young people in rural communities?
Well, that's a good question, and I'm about to get into the difference, at least with utilization of phones and other communications specific to youth. So if we can hold that just for a second.
All right.
We're going to get that. I do see one question that came in. Do you have suggestions of ways that service providers who have good relationships with clients who are struggling might be able to help these clients who have a lot of distrust in service systems in general, becoming more comfortable and trusting with calling strangers on the suicide hotline? So absolutely. The first thing that I would say is that we are clear about who's answering the suicide hotline. Because you're right. On paper, you just see a number that you call, and from the public's perspective, a lot of times you don't know where you're calling or what you're getting. But the interesting point is you might be getting the building down the road that provides these services. You may or may not know of those services. And so I do always I always encourage communication and dissemination of the information around who's responding to crises in your community. So if you have a local crisis center, are they a part of the National Suicide Prevention Lifeline? So you can find that out. And you can actually find that on the Lifeline's website, suicidepreventionlifeline.org. It has a list of all of the 165 crisis centers. And so then it's really identifying and educating a patient. So if you had a patient come in and you were meeting with them and you were referring them to additional care and you said, you know what, if you're having a tough time, I really want you to call this number, you might want to go into a detailed discussion with that patient about what that number is and who you're calling. So it's really educating the providers on what are the resources in which you're referring to. Again, one thing that we want to make mention of is this is not something that's going to be necessarily bound by HIPAA, because we are talking about an individual that's in crisis or they're suicidal. Really, you want to make sure that they are getting the immediate help that they need, and they know where they can go when they need help. So if they're not in crisis immediately, what are you going to do? So make a plan ahead of time. And so that's the thing that I would say about working with those clients, is to not have them think of the hotline as strangers, but educate them on what the process is, who they're going to call, and even to ask questions on the other end of the line. But what you'll see in 2 seconds is there's another way to get a hold of the crisis centers where they won't necessarily have to give a lot of information. So before we hop into that, I'll see if anyone else has any additional questions.
Our next question comes from Gabriel Smart. Gabriel, your line is open.
Okay. Hello. My question is, I heard you talking about grants and stuff like that, and I'm from the Navajo Reservation, the Four Corners area, and over the summer we had quite a bit of suicides with teenagers, and it's kind of hard to get help, with the stuff like as far as suicide prevention and stuff like that. Is there a number we can call to get help, or is there some funding we can apply for? Can you help us out in any way with information like that?
That's a great question. And I would say, regardless, the number for individuals, again, that you experience that might be in crisis would be the Suicide Prevention Lifeline. If you're also aware of any other crisis services in your community, I do encourage that. And I know there's a difference in a lot of the approaches with tribal and then states. I primarily focus on states, but we do have a focus specifically on suicide prevention in tribes here at Samhsa. And so we do have 2 current grant programs that offer funding to federally recognized tribes in the United States. Those are the Garrett Lee Smith grant funds. I talked about the Garrett Lee Smith program earlier. And then also we have a new grant program that came out, Native Connections, that was recently awarded as well. And so you can definitely find out more information about both of those programs on SAMHSA's website. So it's samhsa.gov, and then it'll highlight our tribal approaches, or you can definitely Google Garrett Lee Smith, SAMHSA, or Native Aspiration or Native Connections. And if you want, at the end of this presentation, I have my contact information. You can shoot me an email, and I will provide you with that information. And if you have additional questions, we'll link you up with our tribal lead as well.
Okay, sounds good. Thank you.
Absolutely.
No further questions from the phone at this time.
Okay, perfect.
James, this is Joyce. I just wanted to ask one other quick question. Is that you have, and I think the last caller kind of highlighted this, but what should people be thinking about in their rural communities? Because more and more we have more immigrant populations in rural areas, and the demographics are changing dramatically. What kinds of what kind of process should they go through to really see what's out there in terms of customized things or other resources or planning considerations for different populations they may want to serve?
Again, good question. I think the first thing that you want to do when you're trying to identify what resources are out there are identify the population, and then ask, if I were a member of this population, or if I were experiencing a crisis, where would I go? And what's your first step for reaching for help? So it could be to call the Suicide Prevention Lifeline. There are resources on our SAMHSA treatment locator page. So if you go to samhsa.gov, you'll actually see the behavioral health treatment provider page on the right. It's a web-based tool, so you can actually identify what behavioral health providers are within your area. But again, when we're talking crisis specific, those are going to be, the majority of them are going to be outpatient programming. It's not going to be crisis specific. The crisis specific ones are those historical structures that I talked about that are not currently set up adequately in many areas. And so those are your emergency departments. You may have limited options for crisis stabilization or crisis centers or mobile crisis outreach teams or police. And so again, it's a larger question because you really have to start identifying from the community level, where would you go now if you were needing care? And the goal is not to wait until you need care in a crisis to do so, is to have a plan, identify that, and actually create a crisis intervention or prevention plan, and then embed that within your community. So that would be what I would say would be the first start, is really doing kind of that environmental scan of all of those systems that I told you about earlier, and then we start looking at how technology bridges some of those gaps if you don't quite have the funding to build the structures in which you think.
Thank you.
Okay, so I will continue on in the interest of time. Oh, wait, you know what? I need to go up 2. No, I don't. Did the slide get switched around?
It's just thinking right now.
It's thinking. I wanted to highlight one more initiative from one of our grantees that I thought was just super cool. And it is in its infancy stage, and then I'm going to kind of get into those new ways to communicate. But Tennessee has a Garrett Lee Smith grant, one of those grants I talked about, and it's specific to youth ages 10 to 24, and it's for suicide prevention. So what they wanted to do was build out of Centerstone, which is a behavioral health provider. What they wanted to do was build a technology service package that they would assign to a select number of individuals. So they had to have a few things that were going to be criteria for these. So they had to be built in with their core programming. So again, it had to fit in with their gatekeeper training and their screening of suicidal individuals. And they had to be technology specific, which I'll get into. And they had to have a risk assigned to them, a clinical risk, and they had to have a certain medical condition. And we limited it to the 3 of those participating in their behavioral health services, which were diabetes, obesity, and hypertension. So what they did is, or are doing, is issuing these individuals phones, iPhones, and Fitbits, and on your iPhone you'll actually download a couple different apps. Ginger.io, Virtual Hotbox, and Mobile Iron. They all do something a little bit differently. But the goal was to really start, and obviously you have to voluntarily participate in this program, but they wanted to see what the impact was on behavioral health and physical health conditions with getting more active, participating in treatment, and overall improving your lifestyle. So again, you had this app, and what it did was it tracked a lot of your socializations, your activities, your moods. So you had a mood scan that would occur. It would actually see how active you were, how many, might sound a little creepy, but it's not, how many calls you were placing to friends or family to know how connected you were to your environment, or how many supports you had. And then it would track your movement to see how active you were. And then also, at the end, they wanted to really see, was there any outcomes that could be associated with it, and what were were there positive outcomes and all that. So you would see kind of this continuous cycle of engagement that would allow their clinicians to tailor their treatment to what their behavior was producing. So a lot of times individuals might not know how active they were a day, how many steps you took, were you isolating, were you not. So this is a first step, but this is a great way that they have a pretty robust system, at least in Central Tennessee, for this behavioral health care provider. This was one way that they started looking at some of their outcomes of their higher risk populations and tried to develop something that would give them some outcomes that they otherwise could not get to, could not find. So we're very encouraged by this, and we're hoping to see some positive outcomes of utilizing these services. Okay, so I'm going to go on real fast to the different ways people are starting to communicate, because we talked about what if you're not comfortable, or what if you don't know those individuals in your local communities. Again, so there's been a trend moving away. Well, I don't even want to say moving away from telephonic services or phone services, but we're starting to reach individuals that otherwise would not call in for help. So email really was the start of this, and a lot of people don't think about this, but crisis centers and behavioral health providers at the time thought it was a good thing. You know, if you have a question, comment, concern, here's an email address. So you would say contact so-and-so. Well, it wasn't supposedly meant for crisis services, but what they found all over the place is that people would be writing in, leaving stories of either their depression, increase in symptoms, need of medication, need of immediate help and services. And then what we found is that email might sit in a box. If it came in at, it never came in at, 10 o'clock in the morning. It always came in at, 7, 8 o'clock at night on a Friday night. Well, no one's going to be able to answer that email account until Monday morning, which in a crisis intervention setting is definitely not what we would call best practices. A lot of times you need that immediate response. And individuals just weren't comfortable telling their story over the phone. And so email started really nudging us, crisis services, crisis centers, and then us at the federal level started looking at what are these alternative ways people want to communicate. So we started looking at chat, text, and social media. And so we started thinking about, well, why would we want to use this? Why do we want to use chat and text? Well, we had this increase in requests, again, starting with email. We needed to access populations typically hard to engage over the phone. So there are a lot of populations which did not want to discuss over the phone, and it created a safe space where people could ask for help. It gave an additional way, and it really started decreasing a little bit of the stigma because you didn't have to give a lot of identifying information. And then it created something that we weren't really, I don't want to say prepared for, but we didn't really think about at the beginning, but it makes perfect sense. What we call the online disinhibition effect, it really is the increase of stories that were escalating in crisis. So we got a lot of information from people over a very short period. So sometimes, like through email or chat, people would immediately disclose their crises or their suicidal behavior, which historically we would have to work and really build that empathy and rapport over the phone. Well, we just saw people starting to pour out their stories over chat and text. So text was, we started piloting this at Samhsa with supplemental funds. I believe it was back in 2011. And we had a couple states partnering with local centers, just providing this little regionalized response. We didn't have the funds at the federal level to expand it nationwide. So what we've seen is we've seen public and private organizations that are starting to answer this demand. So here's just a couple examples. The Youth Line in Oregon, the Teen Line in Los Angeles, the Crisis Text Line, for those that aren't aware, that's a national-based texting line for all individuals, and it's not suicide prevention specific, but it is crisis specific. And then also Text Line, Text for Life in Minnesota. And many of these were either created with state or GLS funds or other funds, really starting to get to answer this demand. Now, chat was slightly different for Samhsa. We originally piloted it along with text with 18 centers, and then we had a partnership with Contact USA, which is an accrediting body for suicide prevention, to basically enhance the service and to go nationwide. So we did go nationwide. We went 24/7. I'm sorry, in February 2013, we went part-time, and actually that should say February 2014 went 24/7. And one thing we saw is using chat for follow-up. We do know, again, that is the increased risk of time, so many people wanted to provide outreach. So it wasn't just a one-way communication. It was starting to be used for incoming and outgoing messages. And again, what we found was we were reaching new people. It was people that weren't calling in. It wasn't that people would choose a different way to communicate. It was that people that weren't calling in decided that this was a way they felt comfortable. So again, we see that we are reaching roughly 44% of those are under the age of 20, and 3/4 of them are under the age of 29. With again, a large portion of them are having current suicidal thoughts at the time of entering in. So we see a much higher rate of lethality of those entering in chat than we do on the phone. So those are the two ways that we're engaging through that. One thing that I want to encourage everyone to do is think about how you will use social media moving forward. So it really can, again, be a powerful tool for engaging individuals, but will you use it as a dissemination technique or to generate conversation with individuals? The one thing that you do have to note is that you must have the ability to respond to those individuals if you're generating content in a crisis situation. And so if you're focusing on engaging individuals in crisis, you really have to have that ability to respond and to monitor the incoming traffic. So a very brief history on the Lifeline and with Facebook's collaboration. So Lifeline has been working with Facebook for quite some time. They originally, like most people, created a Facebook page. But what we really started seeing is people outreaching to Lifeline or writing in with suicidal content. So Lifeline started working with Facebook to first have a report protocol for those that were suicidal, just to get individuals help. And if you are familiar with Facebook, Facebook really focuses on community engagement. So they wanted this to be a community approach. So we started in 2012. The Lifeline is a Samhsa grant. We really started looking at this ability to respond to individuals. So there actually is a Facebook chat service if an individual is reported and referred after being screened through Facebook to the crisis center that would respond online to them. Now, the thing that we're working on right now with them, which we're excited, is really building that community-based approach. So we're talking about when to remove content. So what do we do if something doesn't adhere to our safe messaging guidelines, for example? And then we're improving the reporting process. We didn't want to just say, report someone suicidal. But we wanted to really turn it into more of a support mechanism. So we're working on that currently with them to look at that self-care, how to help yourself, and then how to also support a friend or a loved one that's struggling. So individuals can actually send messages or actions to friends, push resources, and then suggest additional follow-up as needed. So really, to conclude my talk, what I wanted to do was look at how you can use technology to currently have the most impact. So here's a little fun polling question. We don't have this one. I just wanted to put it out there. Of how many apps would you guess are available for download on the Android and Apple Store? 200,000 to 1 million, 1 million to 3 million, 3 million to 5 million, or 5 million plus. And these are currently available for download on the store. So since we don't have a poll, I'll tell you right now currently there's roughly 3.1 million apps that are available between the Apple and Android store. So there is a plethora of apps out there. So how do you choose? What are you going to do? So you must ensure that you evaluate the app, how you will implement it, and what the outcome is of all of your technology choices. So the questions to start thinking about, if you're like, okay, I'm going to download this bullying prevention app. Okay, well, how do you know if it's going to have a positive impact? How in a community are you going to be able to tell it's actually helping? Are you evaluating the increase in utilization? So is there a way to track or get feedback from a systems perspective? Or are you able to follow those to ensure crisis services are utilized? So that's more from the individual level. And then the ultimate goal is to see a reduction in deaths or a reduction in utilizing behavioral crisis and crisis services. So you see individuals that are taking better care of themselves and they are able to get treatment when they need and they are not getting into crises. So again, what are the next steps you can do? I talked about it. Identify which components of the crisis response system you currently have. Identify what gaps you have and how these technologies can really bridge and enhance those traditional services. And again, world's your oyster. There's no time better than now because many are low cost or no cost, and it's easy to implement these as opposed to changing different structures. So I like to share a quote. I'm a tennis fan, so I loved growing up watching Pete Sampras and Andre Agassi going at it. And one little quote on from Sampras on being stubborn. He says, during your career, they'll develop a new kind of string that will help you gain a little more spin and speed. Coaches and other players will tell you that the new string, along with a bigger head, will give you the little extra margin for error that you need to win on clay. And you'll resist. You're a little neurotic about your equipment, like most tennis players. But if you want to win that French Open and complete the Grand Slam, you'll need to try something different. Be open to technology. And so really what he's saying is to be open and then to really evaluate the impact because there's always going to be something new developed. And it's going to be very difficult to stay above the curve, but always be willing to look and always be willing to try. And that is the conclusion of my presentation. And so we will see if anyone has any additional questions.
And as a reminder for participants on the phone, to ask a question, you may press star then 1 and record your name. Once again, to ask a question, please press star then 1 and record your name.
And while people are doing that, I will move to this slide. So if anyone has any questions that they want to email me, if you have questions about an app, for example, or if you have questions about funding that I didn't answer, or about a crisis center, feel free to contact me and to shoot me an email or give me a call, and I will do my best to answer it, or I will find someone that hopefully can. So any questions?
And operator, could you just remind our participants again how they can unmute their phones to ask questions, please?
Yes, to ask a question, you may press star then 1 and record your name. Once again, if you would like to ask a question, please press star 1 and record your name.
Okay, well, barring no questions, James, I just want to take this opportunity to say thank you so much for such a wonderful presentation. It was full of information and guidance and strategies. You know, as I heard you speak, I just thought of, you know, the era in which we are fortunate enough to be living in, you know, this era of technology, where we're able to bring technology into the delivery of behavioral health services. You know, and we can, as you said, you know, that last quote from, you know, the tennis player, I think was just such a wonderful way to kind of wrap all of this up, because we do have to think outside of the box as we move forward with ensuring that we're able to provide, you know, or that everyone in our communities across this country have access to, you know, behavioral health services. So again, thank you so much for, you know, your presentation, and, you know, thank you for partnering with us to share the information and that wonderful work that you've been doing. So I just wanted to let everyone on the call know again today, thank you for joining us this afternoon. And as I mentioned previously, this is our last webinar for the 2015 webinar series. We hope that we'll be able to provide additional webinars in the future. And I'd like to encourage everyone that's on the call today to visit the Rural Behavioral Health website. And that website's address is ruralbehavioralhealth, all one word, .org. And on this website, you will find archived webinars as well as a number of resources and information related to rural behavioral health. So once again, thank you for joining us today, and thank you for the work that you do on behalf of children, youth, and families in rural communities all across our country. So before you leave the webinar today, I'll ask you if you just take a few minutes, please, to complete the feedback using the link that is listed here on the slide in front of you. We value your feedback, and we really do use this information that we gather from your feedback to enhance subsequent webinar presentations. So once again, have a good afternoon, everyone, and thank you for joining us today.
Thank you all for participating. You may now disconnect at this time. Speakers, please stand by.